Welcome to Advarra's webinar series. Today's webinar is Mobile Apps, Considerations for Use in Research Involving Human Subjects, presented by Robert Neff, Director of Innovative Technology Solutions at Thomas Jefferson University, and Michele Russell-Einhorn, Chief Compliance Officer and Institutional Official at Advarra. I'm Stephanie Pyle, Manager of Community and Communications at Advarra, and I will be moderating today's webinar. I'd like to take just a moment to tell you about Advarra. Formed by the merger of the research industry's two most respected IRBs, we combined to create Advarra, the premier provider of IRB, IBC, and research compliance services in North America. The combined organization leverages mutual strengths in technology, regulatory expertise, and customer service to serve the increasingly complex needs of the research community. Advarra combines over 50 years of experience in the areas of human subject protections and research compliance. We work with over 2,000 unique institutions and academic medical centers, and we offer global consulting services. Advarra's technology helps make submissions more efficient and accurate and provides exceptional transparency into the review process. For more information, please visit advarra.com. Now, today's webinar is presented by Michele Russell-Einhorn and Robert Neff. Michele is Chief Compliance Officer and Institutional Official at Advarra. She also serves as co-chair for the Subpart A subcommittee of SACARP, and she's a founding member of the National Comprehensive Cancer Network IRB Directors Forum. Michele previously served as Senior Director for the Dana-Farber Cancer Institute Office for Human Research Studies, and she's a lawyer by training. Robert Neff is Director for Innovative Technology Solutions at Thomas Jefferson University. Rob and his team build applications for healthcare and research for use cases across the university and health system. Solutions they've developed include mobile apps for collecting data for clinical research in IRB-approved studies. Rob and his team understand how to develop for the complex environment of consumer-facing healthcare solutions. Wherever it is you're coming from today, we hope that you'll each find some useful information in the presentation that will help you in your day-to-day work. With that, Rob, I'll turn the presentation over to you.
Thank you so much. So I wanted to outline some of the objectives that we have for today's webinar. First is to give a general definition and overview of mobile apps and mobile medical apps. We'll describe some of the questions and issues relating to mobile apps and mobile medical apps that are raised when you're considering them for research involving human subjects, and finally identify issues that need to be considered by IRBs when reviewing such research, including these mobile apps. So we're going to break down this distinction a little bit, first talking generally about mobile apps. So mobile apps are software programs designed specifically for mobile devices, typically a cell phone or a tablet. And there are many examples of mobile apps that you've likely used, whether it's Uber, Google Photos, a camera app, WhatsApp, Fitbit, Facebook. There are numerous of them, and you're likely very familiar with them. You see a bunch of app icons below. Mobile apps, however, are part of an ecosystem for solutions which often include web applications, hardware, and even physical services. So many times a mobile app does not necessarily just live by itself. It connects to a website, a portal, a device, and so forth. So it's important to look at the entire ecosystem of the solution. So what are mobile medical apps? Mobile medical apps are apps that meet the statutory definition for a device. So these are apps that have the purpose of monitoring or improving or otherwise affecting the consumer's health, the person that's using it. And we've seen a tremendous growth and really explosion in the number of apps that fall into this category that have been developed and released recently. So we have some data here that there are almost 100,000 different apps out there, and this is a little bit dated, related to healthcare, and really that would fall into this category. I've listed a couple examples here, and I picked these specifically. So Fitbit is an example of a mobile medical app that has a very specific purpose, monitoring activity, possibly, depending on the specific device, monitoring some pulse and other parameters as well. But that's a kind of very specific purpose and focused app. Then you have an app or a solution, which I'll call Apple Health, which is more of a suite of solutions that are built into the Apple iPhone or iOS framework for working with healthcare data that pertains to or belongs to a specific patient. Then there are apps that are really not necessarily an app, but may manifest itself as a survey in a website that you use on your phone or a survey on a tablet. And these surveys can be very simple to the point where you're just answering a few questions or the patient's answering a few questions, to much more complex where a patient's asked to log in, register, and they're asked repeated questions at different intervals. And then there are video visits, and there are apps that produce or kind of administer video visits and allow the conduit for that. And there are other ways to conduct video visits. So in some cases, there's an actual app, and in some cases, it's more of a technology that happens to be a digital technology that we leverage on our phone. So it's important to look at the type of technology that we're using and discussing. There is FDA guidance on mobile apps, and it's worth understanding that and just taking a moment to discuss it. So the FDA regulates a subset of mobile apps which meet the definition of mobile medical apps. The agency intends to exercise enforcement discretion with respect to the apps, and they've categorized them into different categories appropriately. So there are high-risk mobile medical apps. Some examples of those would be an app that monitors blood pressure and transmits the data back to a specific physician, a treating physician, an app that controls the delivery of insulin through an insulin pump, or any sort of other app that interfaces or controls a device that the patient is using for medical care. And then there are lower risk mobile medical app examples. For example, something more along the lines of a diet tracker or an exercise tracker where people are tracking their running or so forth with. And a great example would be MyFitnessPal. It's important to notice that while the FDA does have guidance on mobile medical apps and how it treats them, whether or not a mobile medical app is FDA regulated or approved should not be the primary factor for considering its use in research. And that's important to note because part of determining how an app should be used or can be used and what the benefit is doing research on it. So it depends on what kind of stage of research you are in that app in terms of how you want to consider it with the IRB. So questions here that we're going to talk about help guide the decision regarding the risk of using these apps in research. And it's not necessarily just whether it's under the regulation of the FDA, like we said. So there are a number of different considerations for researchers when you're looking at using digital technology, such as a mobile app, in a research study or in your research. The first question to orient yourself prior to the key considerations is whether or not your research involves the evaluation of the app itself, or if you're leveraging that app to evaluate something else. And that's a really important distinction. There's lots of research studies that we've seen and that I've seen that where the goal is to determine how efficient or the efficacy of a specific technology or app. And then there are other cases where you're using the app to do something else. So it's important to understand, are we evaluating the app or are we evaluating something using the app? I broke down 5 core different areas to understand about the specific app or technology that you're using before you make a determination of how you're going to use it in the research. And we're going to talk a little bit about those categories, but they are really general considerations, focus on the technology, a focus on the data security and confidentiality, consent in terms of use, and then support and training with regard to the app. When it comes to general considerations and risks related to medical apps, there are a number of different things that we want to consider, and I've listed a number of questions here, and really to pique some curiosity and thought about how the app is being used. So the first question that you might consider is, what is the data that's being collected in the app? Is it strictly research data, and is that all there is? Or is there other type of what we'll call incidental data that's captured by the app? So this might be usernames, it might be metadata about what time the survey was taken, what type of device the survey was taken on, where the patient was or the person was when they were taking the survey. This is all information that sometimes will be collected inadvertently based on the technology that you're using. Looking at whether or not the data that's collected is identified or de-identified is an important factor. So there may be issues where the patient's logging in or the phone number is recorded for the patient that's using the survey or the app, and there are other cases where that's going to be completely anonymous. Where will the data be sent? Is this data going to be stored in a database somewhere? Is it going to be stored on the phone and collected later? Is it going to be shared with a medical record system of some sort? So really understanding the full process of not just what's on the front end for the patient, but where is the data going to go and how is it going to be collected and reviewed later. What are some of the risks to privacy and confidentiality with using the app? And there are a number of them. We'll talk about that a little bit later in the next section, but that's a huge concern. What are some of the risks if the app is not working as intended? We've all installed apps before or installed technologies before, and they didn't work the way we expected. Is there a concern or is there a risk that the app could impact something else that's going on that patient's device, which potentially could impact their care? So that's something that you would absolutely want to look at and consider in terms of technology that you're using. Are there costs to the participant for using the app? This is something that's often glossed over or not thought of carefully, but certain apps, depending on what data is being shared, what data is being transmitted, may end up hitting data limits that a user has on their phone. It may, whether it's a limit on minutes, a limit on data, or so forth. Understanding how the use could affect an individual cost then back to the patient or the user is important. And then, is the app content appropriate for the participant population? So that could be everything from, is the font size the right size? Is the language use the right reading level or the right language? Are there videos in there? Are they captioned appropriately for deaf or hard of hearing folks? So there are a number of different things that you want to look at in terms of how the technology is developed and how it's going to be used in the study to make sure that you're responsible. So now looking specifically at the technology behind the app, there are really a couple different ways that this technology might be used for research. And one is an app such as something from Fitbit or MapMyRun or MyFitnessPal, where it's a fairly commercial app that's then being used and studied as part of the research. But then there are other cases where the researcher, part of a team, will put together an app or a solution, and the research is being done on that solution. So they might build an app and study how well the app works. They might build an app to collect their own data. And in that case, there's an additional level of responsibility that you have. So if you're able to use a commercially built app in the study, you remove the burden from researchers of having to build their own app, which is a whole challenge in and of itself, but it's absolutely something that's sometimes necessary depending on what you're studying. Some of the things that you need to evaluate and consider from a technology standpoint at a high level are, how will the researchers access this data? So I talked about this a little bit in the previous slide about where does that data get sent and where does the data go when it's collected or entered in the mobile app. But take it a step further. Which researchers have access to that data? How is access to that data audited? Is it in real time? Do there need to be notifications? Is there a portal that the researchers go to review that data? If there is, how do they log in? And how is all of that access controlled? That's a critical component that needs to be considered, and sometimes, unfortunately, is an afterthought in some of these studies, because the key part is seen as getting users, getting patients to use the app and submit data, and then not enough thought is given to, well, what happens once the data is submitted? How do researchers access it, and in what format is it? Will devices be provided, or will participants have to have their own device? This is really important because it goes to bias in the study and what technology is supported on what types of devices, how old are they? Is it an iPhone versus an Android phone versus a flip phone? And adding that bias in could be a challenge, and looking at techniques to reduce that is extremely important. Participants having their own logins and accounts goes a little bit back to what we talked about in terms of having de-identified or identified data. And in some cases, you will need identified data, and that's really important. In those cases, how are logins going to be distributed? What are we going to do with lost passwords and so forth? And kind of how those logins are sometimes shared is something that we need to look at. We talked a little bit about what types of devices are supported, but one interesting thing to note is the length of the study. As people change devices over the course of, typical cell phone users may change their device every 2 years. Now that's come down a little bit, actually. How is the device supported through a study that lasts a year or 2 years? And how does the data move from one device, or the app move from one device to another? And how does that impact the study? And then finally, software updates. New phones and new updates for phones come out all the time. And there's a burden that we need to take to make sure that when these updates are pushed, since we don't push them, they might be pushed by Apple or Google or Samsung. How do we make sure that these updates don't affect the apps that we've installed and asked our patients to use on their devices? I do want to make a quick note about study cancellation and how can that be handled, and I think I'm going to talk about that right here. So I want to put together an example. Sometimes it's helpful to frame this with an actual sample of a study that we could do. So this is a hypothetical study in which participants are asked to report their mood via a survey app, and this survey app reminds patients to complete the survey every 3 hours, let's say for a week. The researchers start seeing a negative impact on participants who are monitoring their mood so often. The researchers would like to stop the study. However, the mobile app keeps reminding participants to complete a survey every 3 hours. So obviously this is not an ideal situation, and it raises a number of questions that the researchers probably should have thought of beforehand. For example, should the app have the ability, or should any app have the ability to be remotely reset or stopped? Certainly, whether it's related to what's going on in the study and what the research is showing, or whether it's simply related to a bug or an issue with the app, should there be, and I think the answer is yes, some sort of way to control that app remotely from some sort of central monitoring station? And then, of course, whose responsibility is that? Are the researchers required to review data in real time from remaining participants? So what if the app isn't able to be stopped? What is the responsibility of the researchers who are trying to then stop this study, but the app still keeps asking questions? And if the app is remotely disabled, how will that be communicated? So the communication and working with the study participants is really critical, because again, we're in a situation now where the participants might not be coming in every single week or every single day to report their findings. This is all happening remotely. So how do we contact those participants if we need to? Moving on to data security and confidentiality and access to data. The security of data and the need for participants feeling confident in the way the researchers are handling their data is critical to the success of any sort of clinical trial. It's also required by law. With digital technologies, there are often many different people involved in the technology. So ensuring the data security is even more important and challenging. And let me give an example of that. Technology, a mobile app on a phone, there are many different parties that are involved in having that mobile app working. It's the developer of the mobile app, but it's also the phone itself. So whether that's an iOS phone, it could be Apple, it could be the phone company itself. So whether that's Verizon or AT&T or Sprint handling the data, there are lots of kind of handshakes of how this data goes. Nothing is ever developed by just one company. So it's important to make sure that as data moves along the chain in this process, it's secured and handled appropriately. Questions you want to ask are, where is the data being stored ultimately? We talked about this a little bit before, but it's critical to understand if it's being stored on a cloud service, whether that's Google or Amazon or any one of a number of third-party smaller companies that are doing work like this. What is the relationship that the researchers have with that company, and what is the guarantee that they have that the data is going to be kept secure and correctly with regard to any sort of regulation? Is the data encrypted when it's stored on the device? Is it encrypted in transit? Is it encrypted where it's being stored? What passwords and PINs are being used for the participants and investigators? So this is a major challenge that we've all seen before, that passwords either are too easy or are too challenging. If they're too challenging, oftentimes they get written down, and that defeats the purpose. So what are the requirements for the passwords? How often do they need to be changed, and are they following good practices? What auditing is available for people who access the data? So I mentioned a little bit before about researchers accessing the data and what logging and auditing is available to see who and when they accessed it. That's going to be a critical component of the solution in ensuring that the researchers of the solution could pass an audit of the technology. How is access to the third parties evaluated or restricted? So again, I mentioned data might be stored on Google or Amazon or another cloud provider. How is that relationship managed between the multiple parties that are part of the solution to ensure that only the appropriate parties who, likely in this case the researchers, have access to the patient's data for the needs of their clinical research? And is the device itself collecting data? This is probably not as likely, but in some cases, the data might be collected on the individual device and stored on the device. And if that's the case, is it being encrypted when it's on the device? Do you need a password to then unlock and view that data, or can anyone who gets their hands on that phone then view it? So all considerations that you want to think about when you're looking at what data is being generated by the technology, how's it being stored confidentially, and then who has access to it. So informed consent. One of the neat things that, and I guess Apple pioneered this around 3 years ago, came out with a framework called Research Kit. And one of their goals was to democratize clinical research and make it available through the App Store, through apps. One of the ways they did this was creating a very regimented e-consent process, so electronic digital consent for studies. But some apps use that and some apps don't do that. So it's important to understand e-consent, whether or not that's something that you want to support in your study or not support in your study, and some IRBs do approve that. Is it combined with the mobile app? So is that e-consent the first thing you do or the patient's asked to do when they launch the app? Does it contain all the elements required for informed consent? And is there an option for the patient to choose to complete the consent via paper if they choose? There's also a possibility that the consent is waived based on the study. So in that case, the informed consent is not as important in terms of collecting it. And then there's an option for written paper consent only. So maybe the e-consent is not something that's supported by the study or not something that the researchers are interested in for one reason or another. So there may be an ability to consent via paper to then using the mobile medical app. Terms of use. So in addition to consent, there may be legal terms related to the technology. All of us have seen the terms of use agreement. It's typically referred to as a EULA, an end user license agreement, when you start up an app or a new software program. And oftentimes participants are asked to accept those terms of use prior to using the app. In fact, when apps are often downloaded from the Apple Store, right there in the iTunes Store on your device, you can see the terms of use before you even download the app. And by downloading, oftentimes you're agreeing to those terms. So how is this information explained to the users? These are agreements, and I'm guilty myself of sometimes just clicking right through them. One of the things that we know about the IRB process and informed consent is a great effort is made to explain to the patient what's going on. We need to make sure that we're explaining responsibly to the patient what they're agreeing to in these other pass-through terms when they're using the technology. Do any of the terms in these terms of use agreements comply with applicable research regulations? So this is something that the IRB should want to look at and will review in approving the study and improving the use of the technology. And is there any information in these agreements that should also be included in the consent form? So many of these agreements might talk about where data is stored, who has access to the data, how that access is controlled, and so forth. And should some of those terms and some of that information be moved forward into the consent form so the patients understand it in that section of the consent. Support and training, and this is one of the last of the 5 key areas that you want to look at. While mobile apps are much easier to use than traditional software, it's often a misnomer to believe that you don't need a manual, you don't need support, you don't need training. Even the easier apps will cause confusion for some users or fail due to external factors. So a great example of this is we had patients logging in where they had signed up for a username and password for a specific, this wasn't a research app, it was another type of app, but they signed up using a capital letter and then logged in all lowercase. So we had to go back and review some of our procedures and change the technology on the back end, but this wasn't an issue that the front end researchers could help diagnose, and it wasn't an issue where the patient could really handle themselves. They had to come back to the technology team who had put together the technology to figure out what was going on. So really how the support and training is thought of in advance is critical to making the use of the technology successful. So how will participants get support for the technology, both when they're getting enrolled and ongoing? And the enrollment likely starts in the provider's office at the point where they're enrolled in the study, but there's sure to be technical questions that come up that are not likely easily answered by the researchers or the physician. So how are those questions get answered, and who's going to be answering them? How will simple things like password resets get handled, whether or not it's the patient forgets their password or maybe their account was compromised and they're being told that they need to change their password everywhere? You're going to need to have a process to allow users to do that and make sure that we understand what that process is ahead of time. Is there monitoring in place to ensure the technology is working? So many apps have analytics that the people who've built the app can kind of keep an eye to make sure how many users are using the app, how many downloads, and so forth. So is that monitoring in place to make sure that an app is being used? And if that monitoring is in place, are we making sure that the right people, the ones that are appropriate, have access to that monitoring? And then again, back to overall, once we figure out who's providing this support, what are the hours? These technologies, some of them are great because the patients can use them at home, and that's a key part of it. But that means we can have patients at home, may not even be locally, calling in at all sorts of hours with issues, and who's going to handle those calls in the middle of the night? And do they need to be handled in the middle of the night? So here's an example, and I think this is the same example before that we talked about, but some questions related to this specifically on support and training, things that could go wrong, participants not receiving notifications to take the survey as expected. So that has one of two impacts. One, the patient's not going to take the survey, or two, the patient's going to be calling in and saying, hey, I'm not getting the warnings and notifications as I expected. And because these technologies are acting on a phone where there are a zillion other things going on, there are a lot of technical reasons that could be unrelated to the app that the patient's not getting the notifications. The notifications could be turned off on the phone. It could be set to vibrate. There could be another app that's interacting with it. These are all likely things that require a little bit of additional support that is not going to be something that the research coordinator or physician has the training or the time to troubleshoot. How will cases of participants switching phones, getting a new phone be handled? So we talked about that a little bit before. What should a participant do if the app is repeatedly crashing and they're unable to complete the survey? We've all had apps crash on our phones. This happens from time to time. There could be numerous reasons why this is going on. At what point do we stop troubleshooting and just say, you know, I'm sorry, you're actually not going to be able to be in the study because we can't get it working, or maybe we go to the nth degree to try to figure it out. And then finally, what training and documentation will be available for researchers on how to access the data? So we talked a lot about supporting the patients and using the technology, but there will need to be some support for the researchers in using the technology as well, whether that's them losing their username and password in terms of accessing the data, whether or not they have formatting issues when they get the data dumped out. There will need to be support provided for them as well. And now I'm going to turn it over to Michele to talk a little bit about some of the IRB issues related to this.
Great, thank you so much, Rob. So I'm going to take us in some detail into a discussion of the IRB issues. So first, I'm sure most of you, if not all of you in the listening audience, are familiar with the criteria for IRB approval of research, but I'm going to start us off there. So the criteria for IRB approval of research starts with requirements that risks to subjects are minimized, that risks to subjects are reasonable in relation to anticipated benefits, that selection of subjects is equitable. And we're going to talk about this down the road in this presentation because the use of mobile apps in research raised some interesting issues with respect to selection of subjects. So informed consent should be sought from each prospective subject or the subject's legally authorized representative. And here again, we have a unique issue in that it depends on how the app is being used in the research, but in the case where the app is going to be downloaded onto something like an Apple Watch or an iPhone, there may never be an interaction with the researcher, and so it may well raise questions about who actually is signing up for the research. So the requirements continue that informed consent will be appropriately documented. Where appropriate, the research plan makes adequate provision for data safety, for monitoring the data, and that there are adequate provisions to protect the privacy of subjects and maintain the confidentiality of data. And Rob noted this earlier, but privacy and confidentiality issues are really critical areas to focus on in IRB review of mobile apps. And finally, when some or all of the subjects are likely to be vulnerable, children, prisoners, pregnant women, mentally disabled persons, and so on, then an IRB should make sure that the rights of those subjects are protected, and that's where it becomes very important to evaluate who the prospective participant population might be and how the researcher is going to validate identities. So I'm going to move us to the general requirements for informed consent, which start with the statements that no investigator may involve a human being as a subject in research unless you get the legally effective informed consent of the subject or the subject's legally authorized representative. And it goes on to say, for good reasons, that the prospective subject or representative should have sufficient opportunity to consider whether or not to participate. I think one of the unique and exciting aspects of the use of mobile apps is that it provides opportunities to enhance the comprehension of participants, because Mobile apps and e-consent can have hyperlinks to additional information that can provide additional definitions or background to things that are noted in the consent form. But the other thing is, I think many of us are used to long written informed consent documents where we worry about people flipping through the pages and just getting to the last page where they're going to sign it. And mobile apps and e-consent, they have the ability to time how long somebody stays on a particular screen and not let people move forward without having enough time to sufficiently review the information in each screen. So information should be in a language understandable to the subject or the representative, and no informed consent, whether oral or written, may include any exculpatory language through which the subject or the representative is made to waive or appear to waive the subject's legal rights, or releases or appears to release the investigator, the sponsor, the institution, or its agents from liability for negligence. And this is a particularly important, particularly problematic requirement because, as Rob noted earlier, a lot of these apps either come with end user agreements or terms of use agreements, or they're downloaded onto devices that have themselves end user agreements or terms of use agreements. And if you really read those and you don't just click through them, and I do the same thing that Rob does, I click through, I just want to get to that agree button. These end user agreements frequently have language about how they're going to use the data for research purposes, for marketing purposes, and that they collect incidental data from the device as well. So the requirements for informed consent continue that the consent must include a statement that the study involves research and explanation of the purposes, description of any reasonably foreseeable risks or discomfort. And again, this is an area where hyperlinks could be particularly beneficial. Description of any benefits to the subject or others, and a disclosure of appropriate alternative procedures or courses of treatment that might be advantageous to the subject. A statement describing the extent, if any, to which confidentiality of records identifying the subject will be maintained. And here I think it's really important to make sure that the consent where a mobile app is being used clearly identifies any confidentiality risks that could accrue from participation in the study, whether it's from the direct participation in the study or whether it's because of these other agreements that we've just referenced and how they can have access to participant data. For research involving more than minimal risk, an explanation as to whether any compensation and medical treatments are available. Very importantly, an explanation of whom to contact for answers to pertinent questions about the research. So on the one hand, I think, again, mobile apps provide a unique opportunity because if you have contact information in a mobile app, it might also have an easy link to be able to push something and then you reach somebody down the road. What I'm not entirely clear on is that if you disable an app for any number of reasons, what just happened to the information the participant has about contacting people about that person's former participation on the research study. And of course, you have to have a statement that participation is voluntary, refusal will involve no penalty or loss of benefits to which you're otherwise entitled, and you can withdraw at any time. So then there are additional elements as appropriate, a statement that the particular treatment may involve risks to the subject or embryo or fetus that are currently unforeseeable, anticipated circumstances under which the subject's participation may be terminated by the investigator without regard to the subject's consent. And I think that it's really important to have a very clear description of how this might happen, especially in cases where the app is being used and the participants do not have an interaction with the investigator. So it's really the participant interacting with the app. Additional costs to the subject, consequences of a subject's decision to withdraw, and a statement that significant new findings developed during the course of the research, which may relate to the subject's willingness to continue participation, will be provided to the subject. So here we run up against this question of, once you build an app and you're going to use it in research, how easy is it to revise that app? So that if you down the road want to add something to it, how quickly can you do it? Is cost an issue such that you will not want to do it? If there's new findings, how will you relay that, communicate that information to participants? And that's the kind of thing that needs to be addressed by the IRB. And then finally, the approximate number of subjects in the study. So I also wanted to mention the criteria to waive informed consent there are times when this might be appropriate. And waiver of consent is appropriate when it's minimal risk research. FDA has not had a provision permitting waiver of consent in minimal risk research, but recently enacted that in accordance with the requirements of the 21st Century Cures Act. So in order to waive informed consent, the research has to be minimal risk research. The waiver or alteration cannot adversely affect the rights and welfare of the subjects. Subjects will be provided with additional pertinent information as appropriate, and the research could not practicably be carried out without the waiver or alteration. So here I wanted to provide some reference to the word practicable from a recommendation of the HHS Secretary's Advisory Committee on Human Research Protections. So here it recommended a particular definition of practicability that I think is particularly helpful for mobile app research that looks to use a large population. So let's go to considerations when a research protocol includes use of a mobile app. So I think the very first thing you need to do is consider what's the regulatory framework. Is it a clinical investigation subject to FDA oversight? Is there federal funding? And if there is, does it meet the definition of research involving human subjects? Is it exempt? Can it be expedited? Does it require full board review? And if it's not subject to FDA oversight and there's no federal funding, what regulations or criteria will be applied? And I suggest that following the general requirements for IRB review and research-informed consent from the federal policy for the protection of human subjects in research is the appropriate regulatory framework, even if there's no FDA oversight or federal funding. So what's the range of types of mobile apps? Well, there's lots. I mean, it goes from the Fitbit to the blood pressure monitor to something that regulates insulin production. So you actually have things that are standalone mobile apps, as I mentioned before, where somebody downloads an app on an iPhone or on an Apple Watch or on a tablet and doesn't have a connection to the researcher. And in other cases, you have mobile apps that are key components of an intervention or clinical trial. So when a research protocol includes the use of a mobile app, the institutional review board needs to make sure that it gets enough information to adequately review the research. And then there's the question whether it's expedited or full board review is required and what issues should be addressed in the review process. So at the very outset, it's critical to understand the use of the app in the research. And as Rob alluded to earlier, it's not always clear. So the research could be looking to actually validate the app. The app could be used to collect, store, or transmit participant data. The app could be used to provide logistical support, but doesn't collect, store, or transmit participant data. And these are only some examples of the use of an app in research. Who's the user population? So is it only individuals who own iPhones, Apple Watches? What if somebody owns an Android? Is it only individuals of a certain age range? And if it is, then how are you going to ensure that only people within that limited category are allowed to enroll in the research? This is a particularly interesting one. Does use of the app require use of a specific device? And are participants given a device or can they use their own device? So if they're given a device, is there a cost to receive the device? Are they required to return the device? Is there some kind of penalty if they don't return the device? What happens if the device isn't working? Whose responsibility is it to fix it? And as Rob said, there's also a potential impact on a participant's cell phone usage and text and data plans. And then is use of the app mandatory or optional? So are there alternatives to using the app? Is the app a custom-made app? It's much easier if something already exists, it's commercially made, we know it works. But what happens if it's custom-made? Well, it's important to know that it's functional, that it's compatible, that it works, there's stability, there's security. And how does an IRB know this? Well, this is where I think IRBs need to reach out and get IT and technology expertise either on a consultant basis or to have as a member of an IRB, because we're seeing more and more research come through with mobile apps and with portions of the research that involve a technology component. So if a participant withdraws, how is that withdrawal implemented? Is the app actually withdrawn from the device? What happens to the participant's data? What happens to the participant's access to information about the research if the app is withdrawn. And our participants are required to agree to any end user agreements, terms of use, privacy policies in order to download or access the app, and if so, these should be provided to the IRB for review. And who has access to data collected by the app? So as Rob said, the app doesn't stand alone. It has to be housed somewhere. So if it's housed on an iPhone, an Apple Watch, an Android phone, a tablet, does the device itself have access to the data? And if it does, how does that impact the participants? So where's participant data stored? What are the risks of the app not working as intended? And what support is available for technical questions? And does the app capture incidental data about participants, such as the location of the participants and internet usage? So now the question is, if research comes through to an institutional review board, can it be expedited? Does it have to go for full board review? Well, mobile apps or mobile medical apps not under FDA oversight or subject to FDA enforcement discretion could be expedited if they fall into a category on the expedited review list. For example, an app that notifies participants that it's time to take a medicine would likely fall within a category on the expedited review list. But all other research involving mobile apps should be reviewed by the convened IRB. And I just note here that FDA guidance states that non-significant versus significant risk determinations should be made by a full convened IRB. So let's talk about what the IRB reviewer should focus on. Well, of course, the IRB reviewer must have enough information to determine whether the research meets the criteria for IRB approval of research and whether the informed consent is sufficient. And I just want to again point out issues relating to privacy and confidentiality, who has access to the data. It's very important for the IRB to have information relating to those two issues, along with everything else that falls within a category criteria for IRB review. So what should the IRBs do with these terms of use, these privacy policies, these license agreements? Well, the challenge is that the documents are not always research specific and not always written with research regulations in mind. Sometimes if the app is built for a specific purpose, there may be license agreements and user agreements relating to that app. It may well be that an IRB could require changes in those agreements and that the researchers have control over them and can make changes. But there's many times when those agreements relate to the devices on which the apps are downloaded. And those agreements have different priorities and objectives. They are focused on commercial technology, but they require IRB review because they're participant-facing and participant-impacting materials, and they can impact a participant's decision on enrolling in a research study. So it may well be that we can't change the terms of use and the privacy policies. At the very least, it's important to understand what are the issues in terms of privacy, data access, confidentiality, exculpatory language, what's in these agreements, and do the consent forms adequately advise participants of what is in these agreements. So you might evaluate the research, the use of the app in the research, and if it's required in the research, you might have a paragraph like this in the consent that says, as part of this research study, you will need to use the XYZ app. In order to use the app, you will be asked to agree to a terms of use, which will appear on your mobile screen when you first start using it. And if you decide that you don't want to, then you should not participate in the research. And then we have following that suggested language if the app is optional in the research. So information about data collection, privacy, and confidentiality is often buried in the documents, and the consent form should point this out, particularly since, again, users typically click through these documents and miss this information. Another example of language that one might consider including in a consent form is this. While using the app, data about you, including personal health information, a location, etc., and internet usage will be collected and transmitted to the researchers and may also be transmitted to people outside of the research study. A complete description of this data collection and sharing is included in the terms of use, and the terms of use provides instructions on how to request deletion of your personal data if you decide to do that in the future. Well, I have to tell you, I have never been able to figure out how to do that, but I'm sure that most everybody else in the world is able to do it, even if I can't. So here's where we get into this very difficult, murky area of exculpatory language. So consent forms should not include any exculpatory language through which the subject or representative is made to waive or appear to waive any of the subject's legal rights or releases or appears to release. So it's important to note who's identified here: the investigator, the sponsor, the institution, or its agents from liability for negligence. So what do you do when you've got these documents? You should go through and read some of these end user agreements because they have exculpatory language in them. When you click on those end user agreements, you agree to waive any lawsuits for negligence. How do you reconcile these end user agreements with the consent forms? So one example is to include language that says, while the terms of use may include statements limiting your rights if you are going to enroll in the study, you do not release the investigator, sponsor, institution, or agents from responsibility for negligence, and these statements do not apply to the use of the app in this research study. So that's some issues involved in IRB review of mobile apps, and I've been attending workshops and conferences on this topic, and I wanted to share with everybody some information that I've picked up on investigator issues and participant issues. And this is not a comprehensive table by any means, but I thought it was very interesting to think about the advantages and disadvantages. So what I've heard is the advantage is that use of mobile apps can provide access to a very large participant population, that recruiting people to research studies is much faster when you use an app, and that when an app is combined with clinical trials, it actually can result in a decreased number of in-person visits to the site because the app can actually do things that eliminate the need for people to come back to a hospital or a clinic. And then, of course, additional information and consent forms can be provided in a mobile app with hyperlinks and so on that can provide more background detail and definitions relating to the research. So what I have heard, and this is consistent with what Rob has talked about in terms of support and technology issues, that investigators have found that use of the apps in research requires a significant amount of time responding to participant questions about the meaning of data, about device troubleshooting issues, logistical challenges if devices need to be replaced or returned, and there are issues relating to data attribution concerns and costs for devices and data storage. So in terms of participant issues, and there's only a few here, this is not meant to say that there's only a few participant issues. There are many advantages and disadvantages, but I just wanted to note that in some of the meetings I've been at, participants have said that they've been very excited about the use of mobile apps and the access to real-time data, and the fact that using mobile apps has had an impact on reducing visits to clinics and hospitals, which can be a hardship for people. But some of the problems and disadvantages that have been cited go back to this issue of support. So inadequate support for problems with the app, but one of the really big issues that I thought was interesting is inadequate feedback regarding the data that's collected in the participant's situation. That there's a lot of interest in, if we're putting in a lot of our data into this app, we should be able to get feedback on our data. So I wanted to give an example of an unexpected issue. So when you have an app and it's technology that makes the app and it's coded, and I don't understand how these things are done, but let's say the app provides for an alert or notification, and now that alert or notification is not working. What do? Can you call people? Well, if the protocol and the consent are silent about what your options are, if the participant ignores an alert or notification, or the alert or notification stops working, then you're going to have to revise them to include other means of communicating with participants. And when you're dealing with paper consent forms, it's pretty easy to revise a consent and reconsent subjects, but it's not so easy to do that when you're dealing with an app, and it's very important when an app is in research under IRB review for the IRB to have an understanding of how the researcher will be able to manage any changes to the app. And it could be that there's other mediums used, it could be that there'll be paper used or something else, but at the very least that needs to be addressed. And finally, I wanted to just talk about the equitable selection of subjects. So if you have an app and it's written in English, you're going to limit the use of the app to people who speak English. I'm not sure a short form consent would really work in this situation. It's important to know whether a written consent is an alternative that would broaden the participant population if the app is only written in English. And again, how do you confirm who's actually enrolling in the research? Is it a minor? Is it a prisoner? Are there cognitively impaired individuals? What are the validation tools that are integrated in the research so that you have confidence in who's actually enrolling? So I think that this is an exciting area. It changes the landscape of research. I think that it's going to provide access to research to a significantly larger participant population, but it's not without its challenges. And I think that this is an area where we need to continue to have national conversations about the best way to move forward with this very exciting new part of the research landscape. So thank you, and I'm going to pass it back to Stephanie at this point.
Well, thank you, and thanks to everyone who joined us today. We hope you found today's presentation informative and useful. Thank you for joining us, and have a nice day.